Though I think you give credit to all trustees and all the members of our Christian forum, but everybody knows that you are the soul behind it and you are the person who is doing most of the work, I will say. So today's speaker, I think Dr. Neeraj Chaudhary, most of us have met him and we have heard him earlier also. But just in brief, he is an eminent GI surgeon and with special interest in minimal invasive surgery and robotic surgery and GI onco surgery also. He was trained in All India Institute, Delhi and Sir Gangaram Hospital. At present, he is a senior director and head of Institute of GI surgery, GI oncology and robotic surgery in Fortis Hospital, Vasantkunj. So I request Dr. Neeraj to start his talk. The topic will be robotic surgery, opportunities, challenges and the journey ahead. Over to Dr. Neeraj.
Thank you, sir. Thank you to the Physicians Forum of India for giving me the opportunity to present today on a very important topic, the hot topic of the present decade, the robotic surgery. What are the opportunities, what are the challenges and what are the journey ahead? I am Dr. Neeraj Chaudhary. I am Senior Director and Head and I am the Program Lead of the Institute of GI Oncology, GI HPV Surgery and Robotics at Fortis Hospital, Vasantkunj. We will discuss the topic under following headings: introduction, scope and data of robotic surgery, the challenges which were there in laparoscopic surgery, which we converted into an opportunity in robotic surgery, the problems we face with robotic surgery and what is the future. A great surgeon, Shushruta, he wrote in Shushruta Samhita that a great surgeon is the one who possesses courage and presence of mind, a hand free from perspiration, tremorless grip of sharp and good instruments, and who carries his operations to the success and advantage of his patients. These words stand true in the present era also, albeit the fact that the hands of the surgeon are slowly being replaced by the tremorless grip of the robotic arms. Here we were in 2007 when we used to see that people used to write about India, that robotic surgery, that India is not ready yet, to an article which was published in 2019 that India has 66 dedicated robotic assisted surgical centers with more than 12,800 surgical procedures which were completed in the past 12 years till 2019. And if we see the data in the present, which we are 2025, which is just ending, approximately 45,000 robotic procedures have already been performed this year in India itself. If we see the breakup of these procedures, most of these procedures are general surgery, urology and gynecological and GI surgery procedures. Further, taking down the colorectal ones are very common, especially related to my field, which mainly are low anterior resections and abdominoperineal resection, mainly for cancer and oncology work. The GI surgery work, mainly it is benign and malignant in the upper GI, like Whipple's, the choledochal cyst and gastrojejunostomies. The last 2 years, the journals are flooded with articles related to robotic surgery, and we are seeing the constant rise of robotics and AI-assisted surgery in modern healthcare. There are significant benefits of robotic surgery in terms of patients which help in faster recovery for them, shorter hospital stay, reduced pain, less blood loss, and smaller incisions. For surgeons, it helps in enhanced precision, 3D vision, greater dexterity, and we can handle complex procedures with more confidence, and thereby potentially better outcomes have resulted. There are issues with robotic surgery in low and middle income countries like India, which are related to high cost of implementation, lack of trained personnel, poor network connections, and inaccessible to disadvantaged community. But there are significant benefits in our setup also in terms of reduced physician burnout, minimum SSI infections, the surgical site infections, shorter hospital stay, reduced viral transmission. The role of AI is increasingly being used across all the specialties, including head and neck surgery, general, gynecologic surgery, pediatric surgery, oncosurgery, and urology, including cardiac surgery also. There is a great entrepreneur, Chris Grosser, who once told that opportunities don't happen, you create them. So the challenges which were there in laparoscopic surgery, now we have been able to convert it into an opportunity through robotic platforms. We'll go through some of our work which we have done since I first started my robotic journey around 20 months back. And I'm grateful to God that we have completed approximately 400 procedures in the past 20 months. And the conversion rate from robotic to laparoscopy or open is 0%. So there is no conversion. We were able to handle all these procedures through robotic platform. So this was the first case is a patient who was having recurrent acute pancreatitis since past 3 to 4 months, and he was from Bihar, he worked in merchant navy, he was going into a ship, and he landed in Denmark once, then the company people sent him back to India. He had recurrent acute pancreatitis and with ward of pancreatic necrosis. This is what we did. There was a pancreatic collection in the retrogastric region. Approximately 1 to 1.5, we were just slicing the adhesions because of the dense adhesions in the upper abdomen because of the recurrent acute pancreatitis. We are lysing the adhesions from the anterior abdominal wall. The right side there is a scissor which is a monopolar instrument, and the left side there is fenestrated bipolar. We have reached the stomach, we have opened the stomach. See the clarity which we have been able, the magnification is up to the level of 10x. We have opened the posterior wall of the stomach, aspirated the cyst, necrosectomy was done, stapler was introduced, and cystogastrostomy has been done. We can observe that there is no bleeding whatsoever, and we could go and the camera could go entirely into the cyst, and we could observe that there was no collection inside. And then we are closing the anterior wall of the stomach with sutures. The dexterity, we can do reverse suturing, and all these sutures, suturing is so easy with robotic platform, and the result you can see, the patient was able to go home on post-operative day 3 after such a complex surgery. This is the video of one of our cases which I was trying to elaborate that a patient presented, around 60-year-old patient, presented to us with obstructive jaundice. He had periampullary cancer, and we are proud to say that we are the first in Fortis network to do this through a robotic platform using SSI Mantra system. And this is a video of that. The initial cauterization part is skipped. We have started from the ligation of the GDA. The common bile duct is looped. The CBD is being transected just proximal to the joining of the cystic duct. You can see easily we are able to control the most of the bleeding through even the scissors. The retrogastric tunnel, the retropancreatic tunnel was made. Now we are dividing the stomach through the staplers. This was beyond the pylorus. Now we have looped the pancreatic neck, and now we have gone into the infracolic compartment. The proximal part of the jejunum is being transected, and it will be brought down into the supracolic compartment. The next step is division of the pancreatic neck. With minimal energy sources apart from the scissor and the bipolar, we are able to do the surgery. We'll find the pancreatic duct. The pancreatic duct was identified. It was not dilated because it was a periampullary cancer. It was 3 mm, very difficult to anastomose usually. And now we have divided the pancreas at the neck. The next step is the division of the uncinate process. We are trying to mobilize it from the portal vein, dividing the pancreas. In this patient, there was an abnormal anatomy of the celiac trunk also. The right hepatic artery was going behind the pancreas. It was not originating from the celiac axis, it was from the SMA. So we are now trying to do the reconstruction. The infant feeding tube is in the pancreatic duct. A standard pancreatico-jejunal anastomosis is being done using the classical Bloom-Guard technique. The 3 mm duct, which we are able to see the duct because it is 10x magnification, but usually it is very difficult to anastomose these ducts. Even identification itself sometimes is very difficult. The posterior layer is being anastomosed. The anastomosis is stented, and now the anterior layer is being done using PDS 50 sutures, and then the anastomosis is completed. That's the second step where we are doing hepatico-jejunostomy. We usually start from the left and go it towards the right. The reverse suturing, which is very easy with the robotic instruments, you can see that we are able to take the sutures in any direction, which helps us which is not possible in laparoscopic surgery, and that is the benefit which we attain. So we have completed it both through the right and the left, and this is the anterior layer done. Similarly, this is a stitch to prevent the hernias. The gastrojejunostomy was done next, and the patient was discharged, a Whipple's patient was discharged without an ICU stay and post-operative day 4. And the length of the incision was approximately 4 centimeters. So he is doing fine. The histopathology was PT2, N0 and M0. So the next surgery which I am going to show you is for a young lady who presented to us with on and off vague abdominal pain since past 1.5 to 2 years. This we did in my previous organization. I was head of the Yatharth group. Presented with solid pseudopapillary neoplasm, which is common in that age group itself in females. And this was the first procedure which we did in whole of Uttar Pradesh. I was in Noida. It's central pancreatectomy using robotic platform. This was done using Da Vinci platform. This was the port positions. This we have entered the lesser set. The sphenic vein is being identified, and the tributaries to the pancreas are divided. We were trying to see whether the GDA was involved or not. Because if GDA is involved, the patient, we had initially taken consent for Whipple's also if it would have been involved, but it was not involved, we could see. And then we have transected it proximally. So it was a pancreas preserving surgery. Usually in Whipple's, we are taking most of the pancreas. So for a young lady like this, she would end up in diabetes very soon in her life. So it was a pancreas preserving surgery. These tumors usually are non-malignant. They are locally advanced tumors, locally malignant only. So we were able to preserve the pancreas, and the standard way we did the pancreatico-jejunal anastomosis using Bloom-Guard technique, which I showed you in the last video. The blood loss was less than 150 ml and the patient was discharged in post-operative day 5. This is another case which we did around 3 months back. Young chap around 28 years old working in EY, and he presented with on and off vague abdominal pain. Nobody could diagnose it. Somewhere he got an ultrasound done, and they picked up a big mass in the pelvis, and he subsequently did a CT and colonoscopy, which confirmed to have a sigmoid tumor. But he also had a PET CT which showed a heavy lesion in the lower part of the rectum, just above the anorectal junction. So it was 2 lesions in the same patient, young patient. So this is what we are trying to do. We are opening up the mesentery, trying to separate it from the retroperitoneum, the colonic mesentery. First step is to identify the ureters, the left ureter in sigmoid cases. You can see the iliacs. Now we will be able to identify. Yes, this is the ureter, the peristaltic one. We go to the base of the IMA. That is what we have to do so that all the lymph nodes are extracted. We have just tying above the origin of the IMA. After division of all IMA, we are going down. We have to remove the second lesion down. We are doing the classical total mesorectal excision TME. The anterior denonvillous fascia we are separating. After reaching up to the levators, confirming the lesion that it is above our point of transaction we have divided. We are mobilizing the colon, and then after proximal division, we have introduced a room. We will introduce an angle into the proximal limb, and a circular stapler is then introduced through the anal canal, and the anastomosis is done. And we confirm it through a leak test. There was no leak, and patient did well, and patient was discharged on post-operative day 3. We did a divergent ileostomy because the lesion was, the anastomosis was low down, below the pelvic reflection. This is a patient who around 45-year-old presented to us from Cambodia with diabetes and recurrent upper abdominal pain, found to have chronic calcific pancreatitis with multiple stones in the pancreatic duct. So the step first is mobilization, the entering into the lesser sac. We can see the pancreas down, which is very fibrotic, and the pancreatic duct we have to identify. The stomach is hinged up. Identify the pancreatic duct by aspiration. We then open the pancreatic duct. The stones are visible. We remove all the stones from the pancreatic duct. We have to open the pancreatic duct. It is called lateral pancreaticojejunostomy from the head to the tail, preparing a limb for pancreaticojejunal anastomosis. We will see the dexterity of the instrument and the degree of freedom the robot provides. That we can do reverse suturing in any way. We can easily tackle all the bleed also very easily. The magnification is superb, and therefore the patient results in early recovery, and the patient goes home soon without any much complications. This is a patient in around 31-year-old age, gym trainer, fit, but she had a complete rectal prolapse. So it was hampering in her daily routine. She was not able to work properly. She has to bear children in the near future. So very important is we do not injure the nerves in during the dissection in the retrorectal plane. So we are trying to mobilize the rectum from the retroperitoneum so that we can place a mesh. The first step is this, then we keep on going down till the lower part of the rectum, mobilize it. You can see the redundant rectum and the sigmoid. We have gone down. Then we pull the rectum up and take a hinge stitch to the sacral promontory, place a mesh inside, and we retroperitonealize the mesh so that there are no bowel adhesions to the mesh. The mesh is completely retroperitoneal. There is no problems or complications with the mesh usually with this technique. You can see 1 or 2 sutures more are placed on the sacral promontory so that the rectum is fixed and the mesh is also does not move, does not migrate. So we have completely retroperitonealized the mesh. So there are problems with robotic surgery in terms of malfunctioning with software glitches, mechanical function and faulty instruments. However, it also depends on surgeons' expertise. Surgeons who are less trained blame it on the robots rather than improving their skills. Cost, however, is an important factor in countries like us, low middle income countries with low insurance penetration. There is a talk of consent and medical legal aspect in robotic surgery. Who will be responsible if something goes wrong? The future of robotic surgery is the autonomous robotic surgery. The robots are becoming more and more autonomous. Miniaturized robots with AI integration, enhanced haptic feedback. There will be decreased cost and hence greater accessibility. This was a recent performed surgery, telesurgery. The patient was approximately 2,300 kilometers from the patient. So in conclusion, robotic surgery, I used to tell in the previous discussions that it was the future. Now I believe that it is not the future, it is the present of surgery. Complex case handling has been made very easy. Laparoscopy will soon be the past, and scope is expanding very fast and across all the specialties. Problems like cost and medical legal aspects will determine the increase in adoption. And it is less about the robot operating and more about the surgeon adapting, which will be very important in future. He is my mentor, Dr. Professor Samiran Nandi, because of whom I am here, and this is the team celebration which we completed around 50 surgeries, robotic surgery in Fortis Hospital, Vasanthpur. We have already crossed approximately 125 surgeries in the past 6 months. Thank you for your patience.
Join here.
एक माइक और दे दो। Friends, this is what is called a short and sweet presentation. The message is very clear. Dr. Neeraj Chaudhary is doing complex GI surgeries with robotics in Fortis Vasanthpur, and he is at a stone's throw distance from most of us. But we do not know that he has got an excellent skill set. Therefore, it was my duty to introduce one of the, I would say, preeminent GI surgeons who is using robotics to this wonderful gathering. I am sure you would have some questions. I would request Dr. S K Poddar sir to set the context. And we are also blessed to have Dr. Rajesh Malhotra sir, who is using robotics in a very different kind of a setup. And we would also like to have his feedback only on robotics. He will not be able to shed much light on GI surgery, but I am sure he can shed some light of his experience of usage with robotics, and we'll come to him. Sir, please set the context.
So, thank you, Dr. Neeraj, for showing some excellent videos of robotic GI surgery. Your video of pancreatic necrosectomy, there was no bleeding. I heard in one of the conferences Dr. Adarsh Chaudhary saying, Adarsh Chaudhary, if you don't know, he is one of the best GI surgeons of India. He is my teacher. He was saying that when I operate sometimes pancreatic cases of pancreatic necrosis, I sometimes think that why I became surgeon. Sometimes the bleeding is so much. Even a surgeon like Adarsh Chaudhary said ki why I became surgeon. At times I thought, but this video you showed there was no bleeding. I think it's wonderful. We must give him a big hand. It's the advantage of technology or something different you are doing in robotics. This is my question in pancreatic necrosectomy. Why there was no bleeding?
Sir, robotic surgery is a platform. Robots are a platform in which you were seeing my videos. In my right hand there was scissor most of the time, and in the left hand there was fenestrated bipolar. So in the left hand I was using bipolar cautery, and on the right hand I was using monopolar cautery. We cannot use the both in neither in open surgery nor in laparoscopic surgery. So the point is we can easily control the bleeding. You can see the Whipples, the blood loss in Whipples was 200 to 250 ml total blood loss. That is expected during pancreatic transaction. But otherwise, in the whole surgery, it was more or less bloodless. You can see, you can easily appreciate, because as soon as the bleeding happens, the vision becomes disordered. You could see each and every part of the surgery very easily. Hardly we were using any sections and other things throughout the surgery. So it is a technology which is advancing, obviously. And pericardic necrosectomy sometimes may be nightmares, because of the dense adhesions and inflammation, because of the inflammation it causes. But I think the era is slowly changing, and it is to the benefit of the patient. Less blood loss means less mortality, less morbidity. So I think the future and the present of most of the surgeries now, we are not doing this complex, we are doing lesser procedure, cholecystectomy hernias also, which there was no point discussing because they are routine work. We are doing everything through robotic surgeries nowadays. In my practice, in my hospital, in my unit, approximately 80 to 85% of the work is now moved to robotic surgery.
So, Dominic, excellent. I think that then in rectal surgery, when we were students, there was no laparoscopic surgery even. It was era of open surgery. In rectal surgery, we used to have minimum 4 centimeter tumor-free margin to do a coloanal anastomosis. Then came era where we could do anastomosis with 2 centimeter tumor-free margin. Now with robotics, I have heard that even if you get 1 centimeter tumor-free margin, you can do anastomosis with robot, with the help of robot.
Sir, now the guidelines for the rectal cancer have changed. Usually in rectal cancer, what is usually dictated nowadays is pre-operatively we give some form of new adjuvant therapy in form of usually chemotherapy plus minus radiation. So that is the benefit, and we are able to preserve the sphincter. Even in low rectal cancers, even if we get a margin of 0.5 to 1 centimeter, that is also enough nowadays, and that is resulting in, because the quality of life is very much distorted if it is an abdominal perineal resection. Patient has permanent stoma, and it is not good for the patient. And obviously, we have to keep in mind that the margins should not be positive. We can, with the availability of frozen section, we can easily send a frozen section during the surgery to establish whether when we resected the tumor, the distal margin was free or not. If it is free, we can easily do the anastomosis. We can easily do, there is different type of anastomosis also, which is called intersphincteric resection. Intersphincteric resection is, we go between the external and internal sphincter through the, when we in a lithotomy position, we go through that and then we do an anastomosis of the, it is called colo-anal anastomosis. This was a colo-anal anastomosis more or less. But it was not intersphincteric, but it was colo-anal anastomosis, there was hardly any rectum left. But we could preserve the sphincter. The best part is, we could preserve the sphincter in a young patient. We did not damage any hypogastric nerves which were important for his sexual and urinary and continent functions. So all were preserved. Patient is doing fine. He has started his chemotherapy. The first chemotherapy is already over. The second one is, I think he was here.
Not all two sphincter. Even if you can save only one sphincter, that's enough. So thank you, Dr. Chauhan.
Dr. Neeraj, apart from the wonderful cases that you have shown, you are also doing gallbladder surgery?
Yes, sir.
So you don't refuse them?
No. Okay. They are bread and butter. We cannot refuse them.
No, I just wanted to ask. You are doing them also?
We do everything related to digestive surgery. We do cholecystectomies. We do abdominal wall hernias. Also, we do Nissen's fundoplication for acid reflux. We do all. It is both a combination of everything in digestive surgery, both benign and malignant.
Are you also doing pediatric surgery?
Yes, sir. Also bariatric surgery and sleeve gastrectomy and bypass.
And also
all anal and perineal surgery also.
Okay. Now, you mentioned about the rectal tumors, and you said that prior to surgery you want to give them new adjuvant chemotherapy and radiotherapy. Most of the rectal carcinomas are usually adenocarcinomas, if I am not mistaken. And traditionally it has been said that adenocarcinomas respond poorly to radiotherapy. Your comment on that?
So since those era has more or less
That's not true.
Previously we used to think that the squamous cell carcinomas will respond to radiotherapy and the adenocarcinomas will respond to chemotherapy. So now that is not like that, more or less. Even in esophageal tumors, most of them land up in getting both chemo and radiation, both. So the advantage of that is the tumor size regresses. What radiotherapy does is local recurrence it prevents, and what chemotherapy does it distant recurrence it prevents. So both you are trying to, because all the studies we found out that the recurrence was when the patient came during follow-up, the 2-year recurrence and 5-year recurrence we usually calculate. Most of them had local recurrence, around 60 to 70%, and the rest had systemic recurrence. So it is more or less a failure of surgery. If the patient recurs, if the recurrence is within a year or so. So the benefit of this is we see the biology of the tumor also. We give chemoradiation. Sometimes the PET-CT will not show a metastasis. It is called micrometastasis, which PET-CT will also miss. So what we are trying to do is give a course of neoadjuvant chemoradiotherapy, repeat PET-CT after around 3 or 4 cycles. Still, if there is no tumor anywhere in the body apart from rectum, that means the patient will have very good prognosis after surgery. So that is the benefit which this is called the biology of the tumor. We come to know within the 3 months what is the biology, whether it is very fast growing. If it is fast growing, whatever chemoradiation you give, the patient will have some spot somewhere in the body, usually in the liver or in the lungs. So that is the benefit. So those patients we can easily, these are the patients which should not have been operated before and also. So surgery is a very traumatic thing to a patient. Surgery, I am a surgeon, that doesn't mean that surgery is a very good thing. Surgery is a traumatic thing to a patient. It should be done only when it is required. So those few patients are gone. So we are targeting the patients who will have very good outcome in the future.
What is the cost of the surgery that you did in Fortis, the Whipples?
Whipples costed around 7.5 lakhs.
And what is the follow? How regularly are you going to follow?
Usually the follow-up is the patient was discharged on approximately post of day 4 in this patient. We were lucky enough that he didn't have any complication. Usually the complications are pancreatic leak and all, which were not there in this patient. And patient was followed up. Usually we have a strict protocols. Even if I am not there, my team will ensure that the patient is first followed on post-operative day 3. He comes from the OPD to see whether he is stable, and on post-operative day or discharge day 10. After that, after the 3 weeks are over, the sutures, everything, patient is more or less clear of his problems. Then we introduce him, then we have a multidisciplinary meet. Then the biopsy would have come, the IHC markers would have come. So we would have a multidisciplinary meet to decide what will be the future course, whether medical oncologists will see and decide whether which form of chemotherapy will be required, and he will discuss with the patient the complications of both. Usually it is 2 types of chemotherapy in these patients. One is FOLFIRINOX, which is the standard, and the other is gemcitabine based. So he will decide which is better.
I'm sorry, I missed your talk for some time. There was a call. What was the diagnosis? What was the indication for doing Whipples?
So it was an obstructive jaundice, and patient had tumor in the distal bile duct. So it is one of the most complicated problems for us as a surgeon. If it is a pancreatic tumor, so benefit we get it, the pancreatic duct is dilated. So the operative problems are less. In this patient, because it was a distal bile duct tumor, only the bile duct was dilated. The pancreatic duct was not dilated. It was 2-3 mm, which is standard, which is the normal duct. So the anastomosis is usually a problem, and most of the problems, any surgeon in this gathering would know that the problem with Whipples is more or less a pancreatico-jejunal leak and the problems related to it.
Right. And so far the patient has been doing well.
Luckily, he came to follow up today. He met a medical oncologist in our hospital, Dr. Neeraj today itself, and he is the father of one of my younger RMOs which I have trained. He had trust in me. He came long from Kanpur, he brought the patient, and he is doing fine.
Right. If you did not have a robot, you would still be able to do the job that you did without, if robotics was not there.
Sir, I think that the job with open surgery was also being done. The job with laparoscopic surgery was also being done. This is an advancement.
Okay.
No one would like in today's this. We are going through a phase when in 2000, late 2000, early 2000, we were having daily discussions. I am very fortunate that I have gone through all the eras. My training started with open surgery. Then I was trained in laparoscopic surgery, completed everything in laparoscopic surgery, and then entered the robotic surgery. But the advantage of robotics for the younger generation is that they may not learn laparoscopic surgery. They can directly go from open to robotics.
Right. My last question to you, and I'm sure you'll be honest about it. What is the learning curve with robotics?
It looks easy when I do that, but I know myself that when I was head of the Yatharth hospital from where I started this robotic surgery journey on Da Vinci platform, they were an excellent simulator. For the first 3 to 4 months in the initial part, I did not go to home. For the first 3 months only on alternate day I used to go. I stayed in the hospital and used to do the more and more the simulated thing.
So earlier you were doing with Da Vinci system.
Now I have been trained with both.
So
you are SSI mantra.
You are reading mantra system. So in GI surgery both are equally good.
Sir, the best system which we have is Da Vinci obviously, but it is the other system, the Indian system is approximately 10% deficient in that, but you can see the ripples we have done with SSI mantra. So there is no problem. I am trying to highlight that both the systems we can do complex surgery with equal ease if the surgeon has the expertise.
I would ask for Dr. Rajneesh Malhotra's comments.
Sir.
He's been using robotics now.
Cardiac surgery.
He is a cardiac surgeon. He is the chairman of
I know him.
cardiothoracic surgery, and he has done surgery for many of our friends. I would request his feedback, and maybe he has a question or two to ask.
Yes, sir, please.
So, Dr. Neeraj, it was really wonderful to listen to you.
Thank you.
Really demonstrated very complex surgery, which looked so simple. And you demonstrated as a better like anybody of us can do. So just to put the context, I would say robotic surgery started it was started by NASA for the people who would be in space stations, and if they develop any problem, how they would be able to handle that. So it was decided that we cannot send surgeons, we cannot send Dr. Neeraj and Rajneesh Malhotra and anybody to space to perform surgery of the people who are sitting there. So it was just thought that we can send a robot, it's a machine, and we sitting at Earth can really manipulate and do the surgery. And which, as he said, we have started doing. We have started doing tele-robotic surgery. So we did a tele-robotic surgery. The patient was in India and the robot was in France, and we did robotic cardiac surgery through that. So this is how it started. And robotic surgery all started with cardiac surgery, because cardiac surgery being a complex surgery all started. And we started robotic surgery in 96, 97 with the Da Vinci, the first Da Vinci system and all. And we did that, but for some time there was a gap because other specialties, Da Vinci did not have the interest, so other specialties developed, urology, gynecology, oncosurgery and all. But now the robotic surgery has come back to cardiac also, and we are doing complex cardiac surgery. We are doing mitral repairs, we are doing ASDs, we do Today only I did one robotic ASD closure. So we do complex robotic surgery. And it starts looking very easy when he is doing it, because he has become an expert. As you very rightly said, it has a learning curve. We take 3 to 6 months to become an expert. We have to learn all the nuances of it, and then only we can perform it. And the system, we are proud to know that the system what he has just demonstrated is an Indian system, made by Indian cardiac surgeon. A cardiac surgeon who's trained in cardiac surgery made a robot which is entirely made in. I have been to that facility, then it will go wrong. And you will be amazed to see how they are making this, how this robot is coming, and it is 1/4, 1/3 the cost of the Da Vinci system. So 1/3 the cost, same kind of surgery, yes, 10% less as he said, but you are able to perform it. Every hospital cannot afford 25 crores. Everybody can afford 6 crores, 5 crores. At that too, you can have a leasing system and also different systems are there. So you can learn it, perform it, Indian system, and very easily trainable, very easily. And the other advantage with this SSI system, what he demonstrated, that everybody in the room can see what he is doing. Because everybody has to just wear the 3D glasses, there is a screen, then everybody can see that. Whereas in Da Vinci system, only the surgeon can see. Other people have just a 2D vision, they cannot see what the surgeon is seeing. So they just see the 2D vision. So with this, everybody in the room who wears the 3D glasses can see that, and everybody has a vision that what is happening exactly there. So the nursing staff, the assistant, everybody else. And this system is pretty handy. I have worked on that also. It looks very easy to manipulate and has got much lesser learning curve than the Da Vinci system and can be easily learned. And he has demonstrated us that all kind of complex surgery which he is doing, really remarkable, sir.
Thank you, sir. Thank you.
Thank you, Dr. Rajneesh, for 2 things. First of all, coming, and for that, no thanks to you, but thanks to Dr. Alka, because you are here because of that. And second, for the great input that you have given.
Who knows? You may be due to it.
No, I know. I will go to my masters, Dr. Tulsi sir.
Dr. Chakravarti.
Dr. Chakravarti, you have a question, sir?
Yes,
Okay.
I have questions.
I will go to my another master.
Any question?
Thank you, Dr. Johan. Dr. Neer, excellent talk. Thank you, really mesmerizing for most of us because we are old timers and used to open surgeries. I'm a pediatrician, so I have a little doubt. What's the scope of this robotic in pediatric practice, and have you any experience with that? In case like appendicitis, obstruction, things like that.
So this is the ports which we were using in our surgery were 8 to 9 mm ports. But now recently the SSI itself, in the past month only I have gone to the facility in Gurgaon, they have come up with 5 mm scopes.
Smaller.
Yes, sir. Just like laparoscopic 5 mm scopes and all the fine instruments which are required for a pediatric. Yes, sir. So that it is coming in every field very fast.
So in say near future, we might have robotics for maybe appendicectomy, obstruction of the.
Yes, sir. We have already done colorectal cyst in 9 to 10-year-old child.
Wow.
Yes, I did not show this because of the shortage of time, but we have already done colorectal
Thank you
cyst.
so much, Dr. Neer. Thank you so much. So nice of you. Yes, Dr. Tulsi. Thank you, sir.
Dr. Tulsi sir. Dr. Bimal here.
Let me say, it's a fantastic talk, Dr. Neeraj, and I expected from you. And at the outset, let me say, I'm not a master, I'm just a student forever. And to further Dr. Poddar and Dr. Chauhan's questions, I'll ask later. But let me ask you, Miss, laparoscopy or robotic surgery, how do you choose? Will it depend on the patient and the surgeon's preference and also on the institution where you are? You said 80 or 85% of the surgeries that you do are robotic. What are the 15 or 20% surgeries that you do to the minimal laparoscopy?
They are usually laparoscopy, most of them. because of the usually insurance denials, the patient not affording. Otherwise, if given a chance, I think no one in this world should have laparoscopic surgery. It is, the robotic surgery is so good a platform. It is only the cost constraint in US. Approximately 70% of our GI or everything related to laparoscopic work in GI has been already been transformed into robotic surgery. And I think this is the future of India also. One who will experience the robotic surgery will forget laparoscopic surgery. Although training, manpower, everything is required, but yes, cost constraints are there. When the laparoscopic surgery came, there were cost constraints in that also because open surgery was cheaper. But with time we have seen that laparoscopic surgery, the cost has significantly decreased and it is almost the same.
Right.
So robotic surgery also will have the same cost around 5 years down the line.
Okay. So any contraindications, for example, in reoperative abdomens, due to adhesions, and patients who have, cardiovascular disease, where you need probably, of course you clear the test with the cardiac evaluation and the pulmonary evaluation as well, but patients who are have cardiovascular disease or pulmonary diseases, would you like to probably not go for this and go for...
We have to understand that robotic surgery is an extension of laparoscopic surgery. The principles of pneumoperitoneum still remains.
No sir.
No sir, I am just coming to the point. The contraindications of laparoscopic surgery and the contraindications of robotic surgery are the same. There is no difference. A person who cannot tolerate laparoscopic surgery because of cardiovascular compromise or any other problem because of adhesion or whatever it is, will remain the same for robotic surgery. The radiations and all are a relative contraindication.
I think his question is for surgery where it can be done under local anesthesia like hernia surgery. Sometimes, if you have asked the question, hernia surgery, just listen to it. It can be relevant also for others. Hernia surgery, laparoscopic for also, you need GA, for robotic also you need GA. But if patient is not fit for GA, we can do under local anesthesia. Of course, under spinal it is done mostly, but under local anesthesia we have done many hernia surgery. Still we are doing it very, very rarely, but still we can do.
Why I pointed this was, recently one of the top GI surgeons, I wouldn't like to name, in one of the top hospitals of Delhi, did a surgery, robotic surgery for GI cancer, esophageal cancer to be precise. This patient already had a CAD and the operative time was 10 to 12 hours. The patient landed in acute left ventricular failure, even though his ejection fraction at the time of surgery was 45%. We lost this patient within a span of 3 weeks. Sir, do you have any questions?
So then he was not a candidate for laparoscopy or robotic surgery from the way.
So how do you evaluate that? You evaluate by the cardiac.
Obviously, we have to do a cardiovascular.
So everything was fine. As I said, his stress standing was fine, his ejection fraction was more than 45%. Still he succumbed. So you have to be. Why I stressed on this was laparoscopic surgery, robotic surgery, not laparoscopic, robotic surgery is a time-consuming surgery.
I would not believe you, sir.
So in expert hands like you, probably that would not be so. But here is a practical point which I talked about. He's a foremost GI surgeon, sir. Tell us.
Sir, I think the expertise do matter. Not everyone can do all the surgeries in every patient.
Shall we say it's a bad luck on the patient?
I think we should not discuss it.
I didn't talk about the surgeon's name, neither I talked about the institution. To further Dr. Poddar's question, talk us about the islet cell transplant. Do you do that?
Yes, sir. No, we do not do that here in our institute. So I would like to tell you about the esophageal surgery which we were discussing. Esophageal surgery itself, Whipple surgery itself is a big procedure for the patient. And even if it is an open, there are risks of anything happening during the surgery. So you cannot blame entirely on the robot or on the laparoscope for the patient's negative result. So we have to understand that yes, the operating time, what was the reason for the extension of the surgery, why it took 10, 12 hours. It could be surgeons inexpertise, it could be because of the difficult surgery
Difficult surgery, sure.
then it would be same in the laparoscopic surgery, then it was a patient bad luck. We cannot blame it on anything else then.
Why I asked this question was, does the robot take more time
It depends
as
on
compared to laparoscopic surgery?
obviously sir, in the initial
It does
part,
take, yeah.
in the initial part of this of your career, it will take more time than laparoscopic.
So more anesthesia needed here, that's probably that's the bottom line.
I would remind all of the guests here that there was a time when laparoscopic surgery came and one of my professors, a very intelligent professor, very hard-working, he took approximately 5 to 6 hours for laparoscopic cholecystectomy during those days. So, initial part of the curve, most of the people take more time, but it is the surgical evolution has been like that. The open surgery also previously, which was almost 100% mortality. Whoever patient had pancreatic cancer was doomed to die, even if operated or not. The conditions have changed dramatically. Rectal cancer previously was thought to be a patient almost gone with permanent colostomy. Now we are not handling those cases. We are not seeing that. So the surgical evolution has been great over the past 50 years.
Are you doing EMR in GI gastric stage 1 cancers?
So our gastroenterologist,
You're doing that, sir?
gastroenterologist, endoscopic mucosal.
Yeah.
The gastroenterologist.
Okay.
I am GI surgeon.
Right. Thank you, sir.
Sir, my simple applaud to you. Very nice talk, sir.
Thank you, sir.
I'm curious to know about the rectoplexy you did. So what was the cause of rectal prolapse in young patient, a young person and a gym trainer? Was it related to activity?
Sir, we believe that it could have been because of heavy pulling of weights.
Okay. So
We do not know that, but yes, it could have been that cause. Because she was very muscular, she used to take, she didn't give the history, but some of the relatives told that she also used to take steroids. So we do not know the proper history, but yes, she was pulling heavy weights. That could have been the cause of rectal prolapse.
thank you, sir.
Okay, Poddar sir.
No more questions, so then we must thank Dr. Neeraj for the excellent, I think, presentation. All the videos were, I think, superb. Showed some benign conditions also like rectal prolapse and some excellent malignant conditions video. So thank you, Dr. Neeraj. So robotic surgery is to stay in the future. It is already being used in present era also, but due to cost constraint, we are not using it very frequently, and the Da Vinci robot cost is around 25 crore. So I think most of the only corporate hospital can purchase it. Nobody
But yes, with time we have seen that the insurance approvals have dramatically increased. In our hospital, it is approximately 85% of the time the patients do get approval.
Yes.
Right, the
Good private insurance company, they are now giving approval for robotic surgery. Yes. Thank you, Dr. Neeraj. Thank you very much.
Yeah, in the end, I would like to say that I can just think of two conferences which I attended recently. One was the Asia Oceania Conference on Obesity, of which I was a part of the organizing committee. And Dr. Manish is not here, he was also part of the organizing committee, as well as Dr. Seri Gupta. We had a very important lecture from a foreign speaker. There were 9 people attending that lecture. Believe me, like 9 people attending that lecture. There are 30 people here right now. In the end, where people have gone to take their food, and there were 56 people when we started the CME. So your CME is a hit. Your CME is a hit. I also want to say a few things. There are three purposes to a CME. The first purpose is educational. Of course, we want to learn something from the speaker. The second purpose is awareness. You are aware that Dr. Rajesh Malhotra sir is operating in Max Saket. He is the chairman of CDBS. He is one of the wonderful, most skillful cardiothoracic vascular surgeon. And you are aware that Dr. Neeraj Chaudhary is a wonderful GI surgeon, GI onco surgeon, GI robotic surgeon. There is a third part to the CME. And the third part to the CME is the onus on the delegates. Okay, all of us have little work, and you keep sending that work to somebody, to somebody, to somebody.